Hi, my name is Keith Radbill. I am the Medical Director of Renewus. Today we're going to be talking about hormone replacement in men and women, specifically with testosterone therapy. I wanted to start out by talking about symptoms of low hormones or low testosterone in men and in women. Some symptoms of low testosterone would be a dysphoric mood, anxiety, irritability, depression, lack of well-being, physical fatigue, bone loss, muscle loss, changes in cognition. You might notice people as they get older, they call it like a brain fog, memory loss, insomnia, hot flashes, rheumatoid complaints, generalized body aches. People will notice as they get into their 40s and 50s, they get up in the morning, they have those generalized aches and pains when they first get moving. This does not get better as people age, it tends to get worse. And this is also due to a decrease in hormone levels. Urinary complaints in men specifically, complaints consistent with an enlarged prostate, incontinence, and most importantly, sexual dysfunction, which includes loss of libido, loss of sex drive. So in order to treat this array of complex symptoms, we initially bring a patient in, and the patient can be of any age. It doesn't have to be a postmenopausal female or a male of a certain age over 50. It can really be anyone. And what we do is we do an initial history and physical examination where we look at the symptoms that the patient may be suffering from. We look at their past history. Any medical records that they have with them would be essential. And after the examination, we try to do fasting blood work. This blood work is very encompassing in that it includes an extensive lipid panel. We don't just check HDL and LDL, which is the old-fashioned lipid test. That test is from the 1960s. We use more modern tests that look at lipoproteins, lipoprotein A, lipoprotein, apolipoproteins, and different large density and small density lipoproteins. We are able to better assess a patient's risk for coronary artery disease or atherosclerosis. In addition to the lipids, we also look at the patient's glucose profile. So in other words, glucose metabolism as we get older changes significantly. We become a little bit more insulin resistant, some more than others because there's a genetic predisposition. Some people it doesn't happen at all. But as we notice, as hormone levels drop, our body becomes more insulin resistant. Normally, the tests that your doctor will do are tests called a hemoglobin A1C and a fasting blood sugar. We like to take that a little further because we want to measure leptin levels, which tell us how a patient, leptin is a hormone that basically tells us that we're full. We also look at insulin levels, proinsulin levels, C-peptide levels. We want to see how the pancreas is functioning. In a normal, healthy person without any insulin resistance, their insulin levels and C-peptide and proinsulin levels should be quite low. But as we become more insulin resistant, our body, so the pancreas secretes more insulin in order to meet the demands that increase with further insulin resistance. So with this picture of not just only getting a hemoglobin A1C and a blood sugar, but also looking at a leptin, adiponectin, fatty acids, and insulin levels, we're able to get a much better picture. I like to tell patients, usually when type 2 diabetes is diagnosed, they've already had it for about 5 years. However, with the testing that we can do, we can see a patient who may not have diabetes, may not even be pre-diabetic, but will develop diabetes in 5 to 10 years if their diet and exercise habits don't change. So we're able to intercede 5 to 10 years prior to problems starting, which is really important, especially when you're trying to prevent complications from diabetes, cardiovascular disease, and other issues. After the glucose, blood glucose profile, we also look at your regular tests, electrolytes, magnesium levels. We look at liver functions. We measure the protein in your blood. We also look at the thyroid hormone. Thyroid hormone is much more complex than we think. We have the TSH, which is mainly the test that most doctors go by to decide whether or not to increase or decrease a thyroid medication. TSH, thyroid stimulating hormone, is made in the pituitary gland and tells your thyroid to make thyroid hormone. There are two thyroid hormones, T3 and T4. The active versions of those hormones are free T3 and free T4. And we say it like that because in order to be active, it has to be unbound, hence free. So when we look at these levels of T3 and T4, we really want to treat the patient with the lab tests helping us. So in other words, a range of tests, a reference range where one would consider a test normal, is really where 95% of the population falls in that test. So in other words, for example, a free T3, the reference range that a lab might have would be 2.0 to 4.4, and anywhere in between that is considered normal. But that's really not what that reference range means. It means that 95% of the population falls between 2.0 and 4.4. If, for example, the person is saying that they are tired, they're gaining weight, they feel cold all the time, maybe their pulse is low, and their free T3 is 2.1, well, that's really just above 2.0, and yet they're having symptoms of hypothyroidism. In this case, we would treat the patient with the test just guiding us. So I would want to maximize that patient's hormone level, optimize it. We measure estradiol levels, testosterone, free testosterone, progesterone, sex hormone binding globulin, and DHT. The keys are really the estradiol and the testosterone. Specifically for women, estradiol and testosterone. In a woman of any age, women start to lose testosterone at age 25, and that decreases to half that number by the time menopause comes. Women have 200 testosterone receptors throughout the body. It's not just a male hormone. This is a misconception that needs to be corrected. So with 200 receptors throughout the body, there are numerous functions, obviously, that testosterone has. When we test a woman and check her testosterone level, more than often the level reads less than 12, which is basically 0 because the testosterone cannot be measured. A reference range for a woman would be 12 to 82, their normal reference range. So our job would be, even if somebody is at 15 or 25 and they're having symptoms, dysphoric mood, fatigue, body aches, a mental fog, decreased libido, would be to bump that number up higher in the reference range so that that person not only feels better, but they are healthier. And there are numerous health benefits to testosterone therapy, which I will get in shortly. After we look at the hormone levels, I was saying in women, also in men, we look at the testosterone level. A reference range for a male is 350 to 1200. This is a very wide reference range, and I would not consider that a normal range. If someone comes in and they are a 50-year-old male and they are tired, they have no libido, they have body aches, and they may have lost an inch or two of height, they have a mental fog, and their labs come out to, let's say, 400. Well, that's within the reference range, but the patient is symptomatic of low testosterone. In that case, we would treat aggressively with testosterone to get these numbers into a range where the patient feels better. We are taught as physicians, treat the patient, not the test. When the patient feels good, as long as they're in a safe range, that's where their goal, that's where the level that we're trying to get to is set. We also monitor certain things. We monitor a PSA. PSA is a prostate-specific antigen. This is a test done to screen for prostate cancer. One of the biggest misconceptions is that testosterone will cause prostate cancer to grow or will increase a person's risk to get prostate cancer. These are really false. There has never been a study to show that testosterone will increase a person's risk to get prostate cancer. Let me say that again because it's important. Testosterone will not increase a person's risk to get prostate cancer. The other, I don't know if we can call it a misconception, but the other thought is that if somebody is on testosterone while having prostate cancer, it may make that prostate cancer grow. This is now being disproven in many studies over the past 10 to 15 years. There was a study in the 1940s which showed that men who were on testosterone while having prostate cancer made it grow faster. And then in the 1950s, they started treating by blocking or eliminating the male hormone. However, studies have recently shown that patients do no better than when they are not treated with hormone blocking. We try to get the patient's level to where they are feeling best. We also will monitor a DHT level. DHT is as a byproduct of testosterone that can cause prostatic enlargement. You tend to get more DHT elevation with testosterone creams. We specifically utilize injections of testosterone. You can also do subcutaneous pellets. Subcutaneous pellets and injections should not cause an increase in DHT. They're very safe methods to deliver testosterone. We never, ever, ever give testosterone orally. Oral hormones can be dangerous, testosterone, estrogen, no matter what it is. The reason being is that once a hormone's absorbed, it goes right to the liver and it does what's called first pass hepatic metabolism. First pass hepatic metabolism is where you can then get liver problems and increase in blood clotting factors. So many of the warnings you'll see on testosterone regarding blood clots really come from that. It also comes from anecdotal studies that have never really been reproduced in a double-blind arena. After the hormone panels, we also check your blood count, and we also look at your omega-3 levels. I am of a firm believer that omega-3s are important to a person's health. They're important for your heart, they're important for your skin, your nails, your hair, and important for healing. We like to get your omega-3 level to be 8% or higher. Most patients that we measure are around 3 to 4%. What we do is we will supplement with an omega-3. Now, we also do some genetic testing. The genetic testing looks for, it's called an APOE. What the APOE does is that helps us to determine if somebody is more efficient maybe at metabolizing carbohydrates and fats. It also can guide us with regards to certain medications if we need to treat someone's cholesterol. It also will help with regards to giving an omega-3 supplement. In other words, if somebody is a 3/4 APOE, they may not absorb certain omega-3s. And they would need, for example, an EPA omega-3, which we have. We have 2 different types of omega-3 supplements that we recommend based on these tests. Some other genetic tests that we do are with regards to MTHFR. This is an enzyme, this is a genetic test that tells us how one metabolizes folic acid and B12. Someone like myself could be taking folic acid and it really will have no effect because I am homozygous for the 2 recessive genes, therefore I don't metabolize folic acid. Our body has to methylate it. And in order to do that process efficiently, you have to have either both dominant genes or one dominant, one recessive. And what we do in cases like this is give that person methylfolate. We get the methylated version of folic acid because folic acid is quite important for many functions in our body. It's important for our heart. It may increase our risk for blood clots, fibromyalgia, chemical sensitivity, and many other issues.